So thank you so much for this invitation to share my research and my experience. And welcome to those who have joined the seminar from Hong Kong, from Australia, and from North America. I'll be presenting how I have translated theory-based research into communication skills lectures for pharmacy learners. And for non-pharmacy clinicians, I'm confident that you'll find multiple areas where this research can be transferable to other health professionals' learning. Before I get started, I would like to acknowledge that the land that I work on at the University of Alberta is located on Treaty 6 territory, and that we respect the histories, the languages, cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. So I give this land acknowledgement intentionally at the first and last lecture of class of each teaching term. And I share that I come from a settler background, so French and Irish on my father's side, and English and Scottish on my mother's. And that I want to play a part in working to make things right. I take opportunities in my community and my workplace to learn more about Indigenous history and the ways in which I can be an ally or an advocate for advancing reconciliation between Indigenous peoples and other Canadians. Okay, so to demonstrate how I introduce theory-based communication learning, I'm going to use this first communication lecture that I actually gave to pharmacy learners at the University of Queensland in Australia, and I now use at the University of Alberta. So talking about medication taking is my first in-person lecture with the CCPP learners. So I spent some time introducing myself, my professional experience, and my research interests. And I tell them that the next few lectures I give about communication are based on research, including my own. So for those who are less familiar with the healthcare context in which pharmacists and patients interact, here are some examples. So most people are more familiar with pharmacists working within community pharmacies. So pharmacist-patient interactions are often related to conversations about their prescription medications or advice about over-the-counter products. And they may also include more comprehensive consultations, such as medication reviews. So these involve the pharmacist conducting a review of the patient's medications to find out what they're taking, why, how, and whether the patient has any problems with their medications or in managing their medications. So for primary care clinics, pharmacists may also be working within interprofessional teams in the clinic. And the pharmacy patient consultation may be about a more specific medication issue, or it could be a comprehensive medication review. In hospitals that include both inpatient and outpatient settings, pharmacists may be part of interprofessional teams, and they interact with patients throughout their stay. So this could be on admission, or when they're transferred from one area of the hospital to another, or interacting with patients at the time of discharge. And an example of another context might be where pharmacists interact with patients in nursing homes or in long-term care facilities. Okay. So back to the theory-based lectures I give to the learners. So let's look at how we typically talk to patients about their medications. And we tend to practice this using a step-by-step approach, sort of like out of a recipe from a cookbook. But this raises so many questions. So could there be a problem with this approach? Then I will prompt the learners with things like, so what do you think this might be? And how do you think this might be driven by the pharmacist's agenda? And does this actually encourage two-way conversation? And so does this approach even work? We know about half the population don't adhere to their medications, and we know that the reasons are varied and complex. But I'm thinking as pharmacists, as we continue to hold on to the idea, if only patients understood their medications they'd take. So the trouble with that is that our role tends to be focused on transferring large bits of information to patients. Then we learn a step-by-step process, and later we are assessed by how well we follow this checklist, both in school and in practice. So perhaps we need to rethink or reconsider how we do patient counseling in a different way. So I'm not saying get rid of the framework, but as the learning evolves, and I'm talking to further along students at this stage of your education, let's de-emphasize it. So maybe it's time we rethink about how we talk with patients and not to patients about their medications. So to prompt reflection, I begin by asking this question. What are your goals for each patient counseling session? So for in-person classes, I've asked learners to do sort of a modified think, pair, share exercise for reflection. So alone, I ask the learners to jot down 2 or 3 maybe of their goals for medication counseling, then to chat within a smaller group to compare the goals, and then I ask the groups to share them with the class, and I'll either write it on the board or on the screen or something like that. But for online classes, I ask learners to think about their goals. And I've used, and I do this as a polling exercise, and I've used Mentimeter to share and talk about the learners' goals for patient counseling. Then I ask the learners, now that we've discussed some of the pharmacist's goals, have you considered this? Do you know what the patient's goals are? And I say, well, I'll leave you with this question to think about. But remember, it's the individual's goals for a conversation that direct and shape that conversation. So to effectively communicate with the patient, you need to be aware of your own goals, as well as knowing what the patient wants to get out of your conversation. So why is it important to get this right? Effective communication skills result in meaningful pharmacist-patient partnerships and effective pharmacy processes then ensure patient safety, positive patient outcomes, and high-quality patient care. Whereas poor communication exchanges have been associated with lower patient satisfaction, treatment non-adherence, and negative clinical outcomes. I then tell the learners that the learning objectives for this lecture are to identify, demonstrate, and assess pharmacist behaviors in medication counseling that accommodate patients' conversational needs. Then I tell them I'm going to talk briefly about the use of theory and theoretical frameworks in health communication research. So unfortunately, most health communication research published to date has been atheoretical or not based on theory. And the problem with that is that research not supported by theory often relies on opinion or anecdotal reports in its analysis and interpretation. Theoretical frameworks can add rigor to health research as they provide a structure to plan, organize research, interventions, analysis, and evaluation of healthcare behavior and education. And I'd like to introduce you to the theoretical framework used in my PhD communication research, where I studied pharmacist-patient interactions. I used Communication Accommodation Theory, or CAT, as the framework to interpret the pharmacist-patient conversations. And I've also used CAT theory in studying the impact of theory-based tutorials on pharmacy students' beliefs, attitudes, and behaviors in communicating with patients. So what is CAT? CAT is a psychosocial framework, and it's been widely used in health communication research. CAT describes the behavioral, motivational, and emotional processes that underlie communication exchanges. This theory suggests that it's the individual's goals for any conversation that drive their communication behavior. And CAT characterizes communication exchanges as either being non-accommodative or accommodative. And accommodation occurs when individuals adjust the way they speak to bring themselves closer to others linguistically. Okay. So CAT assumes two-way communication takes place and proposes that there are maybe at least 5 strategies that can be used for effective communication. So I'll start with approximation. So this is about speech production, or how well pharmacists match patients' speech, their volume, their pace, or even their use of shared accents or colloquialisms. Some examples of approximation I observed in my research was when a study pharmacist noticed that she slipped into her northern UK accent when she was speaking with a patient from the same area. Another study pharmacist described how she adjusted her manner of speaking more formal or less formal, depending on how the patient spoke to her. Interpretability strategies are used by pharmacists to adjust their language level and words chosen to make sure that patients can understand them. Pharmacists might also check with patients' understanding using something like the teach-back technique. An example of a pharmacist demonstrating inappropriate interpretability would be when a pharmacist uses complicated medical jargon to describe how a medication works to a patient unfamiliar with the terms. However, one study pharmacist told me that he sometimes intentionally uses medical terms and then he explains them. And he feels that it helps the patient's understanding, and it also empowers them to know what the terms mean. Discourse management are strategies that pharmacists can use to engage patients and keep the conversations flowing in two-way. And they do this by asking open-ended questions, demonstrating careful listening. They use things like nonverbals, nodding, and so on, or back channeling, saying, yeah, to keep the conversation going. And also things like conversational repair, such as allowing patients to save face. In my research, I observed a pharmacist allowing a patient to save face, where a patient questioned whether an error had been made with the discharge prescription provided. But as the pharmacist reviewed the medication, the patient realized there hadn't been an error and was embarrassed and apologized profusely. The pharmacist brushed off his embarrassment by saying, oh, no worries about that. It's super easy to get confused about the way that concentration is written, and guided the conversation back, onto the next medication. Another method used by pharmacists to engage patients was to pause in their conversation and prompt the patient for a response, such as, well, how do you think that might work for you? Accommodative emotional expression strategies are used when the pharmacist uses appropriate levels of empathy and reassurance in response to a patient's healthcare concerns. So study pharmacists used verbal and nonverbal methods such as facial expressions to convey caring and empathy. And study patients describe the importance of feeling heard and feeling valued by pharmacists. For appropriate interpersonal control, pharmacists communicate in ways that promote equality between themselves and patients. I make it clear to the learners that inherent power differentials exist between pharmacists and patients, where pharmacists hold power, so often in the form of information and knowledge that the patient may not possess or may not have access to. Examples of some appropriate strategies that pharmacists can use are to encourage and empower patients to be more active, if that's desired, in their own healthcare through shared decision-making. Pharmacists provide clear explanations and rationale for therapy. They encourage self-monitoring of side effects or changes in their condition, and they connect patients with other health professionals in the community. One study pharmacist used an empowering phrase. She used to say, well, you know you best. So if you're experiencing something unusual, and then we'll go on to let the patient know how to manage that side effect. But the biggest issue related to inappropriate interpersonal control I observed was when pharmacists didn't include patients in the agenda setting phase at the beginning of the conversation. And I'll say more about agenda setting in a few slides. The importance of using a comprehensive communication framework such as CAT is that it provides learners with insights into why communication behaviors occur and why miscommunication is common. Okay, at this point, I presented a lot of theory to the learners, so I switched gears and get the learners involved in some active learning. I tell them that we're going to look at some short videos where communication is done poorly, and I want them to identify the CAT strategy gone wrong in each of the videos. For online learning, I use Mentimeter as a polling app. So I'm going to play this video. There's 3 videos I'm going to play. And so the first one, I'm going to play this. And so the first correct answer in the chat box wins big. So I want you to guess which CAT strategy has gone wrong.
Comprehensive work
Did not reveal any
vascular abnormalities.
Your Doppler was negative
For deep venous thrombosis, so there's no need for chronic
coagulation or an IBC
Your
filter
biopsy was, however, positive
for a mixed anaerobic
non-group-based streptococci infection.
Your BUN and creatinine elevations had us worried,
Rapidly progressive glomerulonephritis.
which could have signaled an autoimmune disease.
What does that mean?
We're not going to amputate your leg.
Huh? You get to keep your kidneys.
Okay. Have we got somebody? Interpretability, yes. So I'm not sure who Emmy Barlow is, but I think you were first in. So you're the winner. All right, we'll go on to the next one. Okay.
Comprehensive work.
Hold on.
Did not reveal any
Oh,
Vascular abnormalities.
Your Doppler was
to get this.
Comprehensive work.
did not reveal any
Vascular.
Here we go. Okay. Okay, we've got 3. Oh, Emmy Barlow is off to the races. Yes, discourse management. Oh, emotional expression. Oh, no, that was somebody, maybe that was the last one. So, I'm sorry, I didn't see that one from the last one. But the main one is interpretability, but yes, there's emotional expression there as well. Clearly, they're not picking up on the concerns of the patients. But in this one, discourse management, yes, listening carefully. Okay, let me see if I can get this one right. I think it's my laptop.
It is crucial.
It's user. There we go. Oh, I got it. Okay, this is our last one.
I am scared and in a lot of pain. Could you please take a break from being you for just a minute and try being, I don't know, comforting?
I'm sorry. They're there. Everything's going to be fine. Sheldon's here.
Okay, let's see. Yes, for sure. Emotional expression is probably the main one I'm going for here. Thanks. Okay. I know. Get the.
I am scared.
There we go. So, what should pharmacists do? They should improve the way they communicate with patients because the research shows that patients are not getting what they need from their interactions with pharmacists. Okay. So let's start focusing on what patients want in their discussions with pharmacists about their medication. So here's what the literature has reported. So well-explained information, easy to understand language. They want information both in verbal and written formats. They don't want their conversations rushed, so they want lots of time and well-paced conversations so they've got time to ask questions and have their questions and concerns addressed. They appreciate kindness, reassurance, and they want to be heard and listened to. And they prefer friendly pharmacists, not surprising, that listen, understand, and show a genuine interest in them. And they want to feel empowered and be treated as an equal. And they want to be given enough information to make appropriate clinical decisions. Okay. So next in the lecture, I introduced this. So this is a communication assessment form for the learners that will be used for peer assessment. So this form has been adapted from an actual form I used in the communication research with the hospital pharmacists and patients. And I've modified it since a number of times based on the results of this research and other research. So here's how the form works. So while they're observing their colleagues in a role play, they are to think about the conversation that they're observing between the pharmacist and the patient, and then rate the following statements to indicate their level of agreement, all the way from strongly disagree all the way to strongly agree. And I say sometimes some of these statements don't apply to the scenario. So then just choose for or neither. Okay, so let's review the statements, and and I say ask the learners to ask any questions as we go through them. So the first one, the pharmacist asked early in the conversation whether the patient had any medication questions or concerns they would like to talk about. So this is the agenda setting phase, and it's related to interpersonal control. And agenda setting gives patients power by having an input into how the conversation will go. So some believe that doing so takes too much time. And I could argue that it doesn't. And in fact, it can be time saving. So some physician communication research reports an average of about 90 seconds increase in consultation time with agenda setting. But the important piece is that it avoids the doorknob concerns that are raised by patients as they're just about to leave. And these concerns can often be the most important issue for the patient. As well, patients who have unvoiced concerns may not be taking in the information that's being provided to them. So they're focusing on something else that's bothering them, which then makes the well-intentioned patient counseling really a waste of time because they're not listening. A few study patients told me that they were already comfortable with their medication information anyway, and but they were being polite and they listened to the pharmacist anyway. So finding out what the patient wants to know and needs to know ahead of time lets the pharmacist be more impactful and efficient in the patient counseling. So number two, the pharmacist paid attention and listened to issues raised by the patient about their medication. So this is related to discourse management, listening carefully and responding appropriately to engage the patient. Number three, the pharmacist avoided using medical terms that the patient would not understand or explain their meaning if medical terms were used. So this is related to interpretability. And so there's exceptions, of course, for using medical terms. For example, some study pharmacists use them when counseling other healthcare professionals who would often self-identify to the pharmacist that they were a health professional. Number four, the pharmacist demonstrated verbally and non-verbally that they thought that the patient's concerns were important. So this is related to emotional expression. And I remind learners to use empathetic verbal expressions and nonverbal, such as body posturing, facial expressions, so leaning in, and appropriate facial expression. Okay, so number five, the pharmacist paced the conversation so the patient had enough time to ask questions. So this is about engaging patients and keeping conversations going, but it's also about skillfully redirecting topics when the conversation gets off track. So number six, the pharmacist asked permission from the patient to ask specific questions. For example, maybe it's about lifestyle, medications, medical history, and they explained the rationale for asking these questions. So this is about interpersonal control, and it's about appropriate and careful use of signposting or bridging statements that are often used in the medication history process. So I recently attended a trauma and equity-informed practice for pharmacy led by an Indigenous man. So he talked about cultural safety practices and the importance of seeking permission to ask medical questions. So not doing so can trigger trauma in someone who's had negative healthcare experiences. Seeking permission is a respectful practice that gives patients power and promotes equality between pharmacists and patients. Number seven, the pharmacist encouraged the patient to interrupt them with any questions they had. This is related to interpersonal control and promoting equality. I found that some study pharmacists controlled the conversations, being overly task-oriented, and they didn't allow patients to interrupt them or were impatient when questions were asked. Number eight, the pharmacist explained medication information to the patient in a way they could easily understand. So this is related to interpretability and the use of easy to understand phrasing. So this can be done graphically as well. And I found a few study pharmacists would draw simple diagrams to help patients understand how their medication works. Number nine, the pharmacist spoke respectfully to the patient. I think this is related both to emotional expression and interpersonal control because it's about demonstrating a caring and thoughtful attitude, but it's also could be about promoting equality. Number 10, is the pharmacist re-emphasize the key discussion points with the patient near the end of the conversation. So this is related to discourse management and interpretability. So the pharmacist effectively organizes the wrap up of the conversation and also makes sure that the patient understanding has taken place. Okay. So next, after I've given that, and we've had some discussion about what these statements mean, if there's any questions and so on, I tell the learners that I'm going to be putting them into breakout rooms. So this is obviously for the online learning, to do some role plays and practice their communication skills. So these role plays are case-based, but there are no drug-related problems to solve. So they're really for practicing communication only. So I say, if you find a drug-related problem, that's my bad. I've messed up somewhere in the case. So before learners access their group's case, I ask the learners to decide who's going to be the pharmacist and who's going to play the role of the patient. So just wanted to make sure that the pharmacists only look at the pharmacist page and the patients only look at the patient's page. So the rest of the groups are assessors who evaluate the pharmacist's communication skills based on the assessment form we had just reviewed. So I ask learners to make sure that they have an opportunity to be an assessor for at least one of the cases, so they each have a couple cases. And then I let the learners know that I or one of the other facilitators will be dropping into their breakout room at some point to help out, give some pointers, address concerns, questions, that kind of thing. So I'll give you a click on the case here. Can you see this? Yeah, okay. So just to give you a little, I'll just sort of shoot through this a little bit. But so basically the first page is just about, who does what, that kind of thing, some guidance, also some links to the tool that we just looked at. And, I remind them again about the pharmacist and patient's goals in the, so the first page is the pharmacist. So looking at what are the goals, like really wanting them to think about what the goals are. This was a new prescription, some antibiotics for, I think, diabetic foot, this one, yeah. So then here's the patient role, and then what their goal is, and what they're trying to get the pharmacist to address in an indirect way to pick up on their cues. Okay. So I also have a facilitator guide for each case as well that I give to the facilitators that help me out. Okay. So with about 15 to 20 minutes left in the class, I bring them back to the main room for a debriefing, and I'll start off with something like this, like, okay, you've been applying CAT in your role plays and how you assess your colleagues' communication skills. So you'll continue to see these communication strategies throughout these communication lectures. And then of course I encourage the learners to ask any further questions about the materials or any comments on the materials that were covered in the lecture. And if time permits, I prompt the learners for some class discussion, or if not a time, I get them to reflect on this. So, I ask them, how do you think this learning and work with the communication strategies affected your patient counseling practice in the role plays? And, if they say, hey, I didn't affect me at all, or that sort of thing, then I kind of ask, well, so what do you feel that your key aspects of your medication counseling practice are that make it effective? Okay. So I'd like to share the next steps planned at U of A in expanding the theory-based communication skills training. So a little background, a bit of background about the Faculty of Pharmacy. So there are 3 instructional streams. So there's pharmacotherapy, and that's kind of like the nuts and bolts about the drugs and how they work in the body and so on. And then there's the patient skills labs, and those are really practice specific. It could be anything from problem solving, communication skills, it could be calculations, different scenarios, interprofessional practice. And then there's something called BASE, and that's an acronym for behavioral, administrative, social pharmacy, and evidence-based aspects of pharmacy. So it's really a hodgepodge of everything else not already included in pharmacotherapy and practice skills. And I've already used the CAT-based communication learning in the base stream of the CCPP program. I first introduced it in term 2 of base, and then I referred to it again in term 3 of base. This year, we're planning to expand the use of the CAT-based communication assessment tool in the patient skills labs, so both for formative and summative evaluation, once I've introduced it in term 2. So I first introduced it, and then they're going to start using it in the skills labs. And then later on, we're hoping to integrate it into the pharmacotherapy. Okay. I'm also looking at some research opportunities always within the CCPP program. And I'd like to build on the previous pharmacy education research I've done in Australia with final year pharmacy students. So this was a longitudinal study, and it investigated the impact of CAT-based communication skills, training on self-reported attitudes, beliefs, and behaviors about communicating with patients. And I'd like to do a version of this and maybe in a little different way because they're different types of students, but to study the impact of the CAT-based communication skills training on the CCPP program learners and do this over time as well. Okay. So in summary, using CAT as the theory that underpins communication skills training can provide learners with insight into why communication behaviors occur and why miscommunication is common. So I've found CAT to be effective because its strategies are sufficiently comprehensive and they can be integrated into learning experiences that include peer feedback and encourage reflection on their communication behaviors. So these transferable skills can also inform students' learnings in many types of professional interactions. So I want to thank you so much for your attention and open it up if there are any questions or comments, or if you've got some ideas for me, that'd be great too.